college is actually a little, puts a little more scrutiny on hepatitis B. Again, because it's basically because of the virulence of the disease. So again, if you have hepatitis B as a surgeon, basically you need to have convened a panel of healthcare providers and other surgeons to look at your clinical status, your patient load, and determine whether it's appropriate for you to continue practice in the current setting. Basically, it's all about patient safety. Hepatitis C is a much different disease. Again, it's estimated to probably be about 0.5% of the population. That is probably an old number. Again, hepatitis C is an indolent disease that many people don't know they have. I actually had acute fulminant hepatitis C, but most people with hepatitis C never know they have it till they get chronic sequelae of hepatitis C. Again, in urban populations, the seroprevalence can be quite high. Pathogenesis, this is an RNA virus, but it's tropism for the hepatocyte, and the way it exerts its effect is very similar to the hepatitis B virus. Again, it's monitored with hepatocellular enzymes, HCV antibody. The hepatitis C antibody is really only a marker antibody. It does not confer any basically killing of the cell. It basically is just a marker. With respect to transmission of HCV from the patient, God bless you, to the healthcare provider, there is a moderate risk for exposure. It's probably in the same range as HIV. And again, there are numerous documented cases. Again, the number of cases is really difficult to document because we don't know the full extent of the folks that are actually infected with hepatitis C virus. Interestingly, if you're infected with hepatitis C, it confers absolutely zero immunity to getting another infection with hepatitis C, including the same genotype. And there are at least 11 different genotypes of the virus. So there are several experimental studies that have shown that basically any other type of therapy, the passive therapy to date doesn't work. However, the good news with hepatitis C is that the antiviral therapy has actually proven effective recently. So they progressed through interferon with combination of ribavirin, and now they're on combination antivirals. And in most patients, particularly those that are naive to treatment, they can affect a cure of this disease. Social implications are the same, and practice implications are really pretty minimal. Basically, it's that there are no specific practice implications related to the disease itself. There's just a disclaimer, as with HIV, that you have to use your best interest or keep the patient's best interest in mind when you're operating on patients. It's all about patient safety. Now, exposure management. If you get exposed, this is very important. You need to minimize the contamination. So if you get stuck, get the needle out of your finger. If you get cut, get the knife or whatever cut you off of your skin and get it out of the wound. Then you need to clean the affected areas briskly and thoroughly. And most importantly, you need to report it, and you need to report it expeditiously. I'm not going to single anybody out here, but I would bet there are people in this room that have been stuck in the operating room and look at the patient and ask the anesthesiologist if the patient is hepatitis B or HIV positive, and if not, I got better things to do. You have to report it. It's really in your best interest, because I learned the hard way. So that when you report the exposure, you'll go to an expert, and it depends, what your status is and what your individual hospital has for the reporting system. They have to be available 24 hours. Obviously, it's a confidential process. They will test you and treat you if it's appropriate and follow you up. The exposure protocol of things you have to be able to document: the date and time, details of the procedure performed, the details of how the exposure occurred, the details about the source, whether the patient was had known risk factors, and if not, that patient should be consented for a blood draw to test them. Then again, details about the counseling and post-exposure management and follow-up. So with respect to bloodborne illness, it's very important to manage this potential risk with prevention. Prevention goes a long way. Education. So there's a couple of bullets in there. Again, particularly with respect to how what you need to look for and how you document it. It's imperative that you document it. Prophylaxis, and lastly, as we talked about, evaluation and documentation. Now, another issue that really gets very little attention, but is actually a significant risk to surgeons and those in surgical subspecialty, is actually ergonomic factors. So this is a case presentation. It's a 50-year-old male faculty trauma surgeon with chronic neck and interscapular pain and intermittent right-sided radicular pain, and the patient is right-hand dominant. He's got DJD and mild C5-C6 disc protrusion. He's had multiple steroid injections and 7 medial branch blocks. So if you hadn't figured it out, that's my neck x-ray also. So again, this is actually has significant potential to cause disability in folks that are in the realm of surgery. So ergonomics is really about designing jobs and your work task to fit the folks that are doing it, not the opposite. It's more complex in surgery for a number of reasons, because there's the other factors, including the patient at the receiving end. It has to include this. It has to be sort of tailored to the operating surgeon. With respect to there's several things that with respect to the ergonomics that come into play. Obviously, how much effort and how much force is applied, how often you do it, and your posture. The basic ergonomic tenets is work activities should basically permit you to kind of adapt to several comfortable positions. You need to use the largest muscles to do your work. And most of your work should be done in sort of the mid-range of the range of motion. Now, with respect to surgery, again, some of the specific elements that make surgery challenging are standing in static postures, particularly if long cases, particularly if you're leaning over, particularly a wound that has a difficult exposure, causes muscle fatigue in the neck, the lower back. The standing on hard surfaces actually causes significant trauma to the feet. And again, anytime, as many of you know, if you get in a position where, you get into a recess in the body cavity that you're working in that's difficult to expose or visualize, then you end up in some really funny postures. Again, for that day, not a big deal, but over the course of a career can be challenging. So with respect to open surgery, again, the things that hurt us are the forward flex back, leaning our neck forward over 30 degrees for a prolonged period of time. They say 2 hours is kind of where you start to have significant problems. Again, if you have longer cases, more challenging or more complex cases, this effect is going to be exacerbated. And again, after about 4 hours, you kind of hit the wall. You're mentally exhausted and might not have quite the same dexterity as you did when you started the case. Now, these factors are also present with minimally invasive surgery. Actually, probably even more so with minimally invasive surgery. So I actually got interested in this when I was at Maryland, because one of the professors was Adrian Park. And Dr. Park was actually one of the pioneers in surgical ergonomics. And when still everybody thinks it's kind of fluffy, but back then everybody thought it was fluffy. But it's a big deal because it's talking about the care of the healthcare provider, the care of the surgeon. And about 90% of surgeons have some sort of physical symptoms related to, not necessarily disability, but physical symptoms related to their practice. It could be eye, you can see it's basically, it runs the gamut. If surgeons participated in 150 to 200 cases a year, they were at higher risk. If they had cases that were longer or more complex, you cut that in half. So that's, again, that's, you cut that caseload down to 75 to 100, where they start experiencing significant problems from their ergonomic challenges. The main source of symptoms were described as instrument design, and about 40% were sort of operating room features. The urologists are likewise have the similar problems. So this is a study done by a group of urologists that noted anywhere from a 30 to 50% incidence of physical symptoms related to endoscopic urologic surgery. Robotic surgery doesn't preclude you from having symptoms. Actually, robotic surgery, the amount of physical symptoms associated with robotic surgery, and robotic surgery is really sort of on the cutting edge, and we see that the number of robotic procedures is probably only going to increase. You can see that, again, the robotic surgeons are experiencing the exact same type of symptoms as the laparoscopic surgeons, particularly with issues with the neck and the back. So the neck and the back are big issues, as we sort of highlighted at the beginning. And the fingers is, one is using the instruments, and also part of that fingers is probably radicular symptoms referred from the neck. And you can see with respect to surgery, urology, and gynecology, we all have similar ergonomic challenges. With respect to minimally invasive surgery, with respect to monitor positioning, it's best if you put that monitor right in front of you, between you and the organ you're operating on. It's sort of that coaxial view where you're looking at your motor, and your visual axes are on the same path is really the best. When you have a monitor placed over the side, that's called coaxial, and that's actually ergonomically bad for you and causes a fair amount of neck symptoms. So basically, by a straight line principle, what you want to do is triangulate your instruments appropriately, so that you have, again, the monitor between, or the pathology between you and the monitor. Operating room table height. Now, the operating room table height really needs to be tailored to the operating surgeon. If he is 8 feet tall or 4 feet tall, he or her. And everybody else needs to accommodate, because the primary operating surgeon is the most important individual in that room. The performance can be, and patient safety can be affected if the table height is inappropriate. It's generally lower for minimally invasive surgery, and optimally in minimally invasive surgery, if you put your elbows at 90 degrees, you want to be working from from 90 degrees down to about 10 centimeters below that. The port placement, the standard port placement is basically is what we've always done. We put them, we grossly triangulate it. We know where the gallbladder is. We've always put the ports in a particular area. But really, probably the optimal approach is to, again, look at each patient individually and try your best to use a more scientific approach, thinking about organ depth and being able to optimally triangulate the pathology with respect to, and using the appropriate instruments. There are challenges with ergonomics of hand instruments. Most of us in the minimally invasive use the instruments with the rings. The rings actually cause a significant amount of hand pathology if you do a lot of minimally invasive surgery. There are lots of different types of nuisance and actually real disabling pathology from those ring type of instruments. So you can see there's been a number of companies that have come out with a myriad of different types of approaches to look at or to deal with the hand issue. Some of the other issues with minimally invasive surgery include sort of the length of the instrument and the so-called fulcrum effect, and that's really again, you need to think of how you're going to access that organ from a scientific perspective. The amount of force that's required to grip the organ, or to actually to grip whatever your work surface is. And it's basically it's a one-size-fits-all, or it's actually, it's a regular, or it's a bariatric set. So they tend not to be tailored, and you don't get a lot of haptic feedback. So if you think about it from an ergonomic perspective in minimally invasive surgery, there's your optimal stance is again, the pathology is between you and the monitor. The monitor is 60 to 70 centimeters away. Again, that's so your eyes don't have to do an extreme amount of accommodation to focus on the picture. And again, you can see that cartoon there, that the optimal working stance is that surgeon is working with his elbows slightly below 90 degrees. So also in the operating room, although less, there's no patient case for this. Although less frequent, can have significant potential for causing harm to the surgeon and other healthcare workers in the operating room. So exposure to anesthetic gases, I would imagine all of us have been in the operating room. We've gotten a whiff of fluorine or a whiff of halothane. But if you have extended exposures to that can actually be quite a significant problem. It's estimated that about 250,000 healthcare professionals are exposed to waste anesthetic gases and end up with occupational illness from it. So many of us are exposed, but about 250,000 actually get illness from it. So the exposure to the waste anesthetic gases can occur for any number of reasons. Again, poor work practices. Again, this will depend on your hospital environment. If you have any kind of leak in your system, if your machine is inadequately maintained. Also, if you're doing any type of airway procedure. So either if you're doing a tracheostomy or you're doing an upper airway procedure or an upper endo, you might end up with a fair amount of waste gas exposure. In addition, in the PACU, as the patient off-gasses that anesthetic, there's also a potential to get significant exposure in the PACU. And the two basic waste gases are nitrous oxide and the halogenated compounds. The nitrous oxide, both of them can cause the same basic effects. That if you get a big dose, it's like getting anesthetized, so you can have loss of consciousness or nausea, dizziness, any kind of neurologic symptoms, sleepiness. The nitrous oxide specifically causes fertility problems and miscarriage. The halogenated compounds have been shown to be mutagenic, cause miscarriage, and in a significant enough dose can cause liver damage. Now, we don't actually, as surgeons, we don't really deal with this, but there's systems in the operating room to remove and scavenge those gases. There's active systems and the passive systems. The active systems basically suck vacuum the gas off after it's used to scavenge it. The passive systems basically force enough air into the room that any waste gas is pushed out of the room into the outside environment. In addition to the gases, the probably a more significant issue with respect to aerosolized waste in the operating room are toxic fumes and aerosols, particularly when we do any kind of surgery that's going to develop that we use electrocautery or lasers in. Interestingly, the standard surgical mask that we have in the operating room, it actually filters out very little, unless it's very large particles, less or more than 1.1 microns. There are you can see there's a number of different types of energy sources that can generate smoke or with energy in the operating room, and a number of those, many of us use in our practice. So you can imagine that when you vaporize tissue, if you get it in your eyes, it can certainly cause ocular irritation. But in that plume, there are also significant toxins So there's actually one study out there that if, just vaporizing tissue for a small amount of time is the equivalent of smoking 6 cigarettes. So there's a significant amount of the same toxins that are in cigarettes that are being basically aerosolized by that energy source. However, what's different is it also has a significant potential to aerosolize live virus and live bacteria. So the health hazards to the OR staff, again, so there's health hazards to the OR staff and also to the patient. We already talked about the health hazards to the OR staff, but the patient can also have issues with respect to that in that they can actually accumulate, depending on, again, the size of the wound we're talking about, they can actually accumulate some of those toxins through that wound, and also they can actually have a significant increase in their methemoglobin. One other thing that I found in my research that I found kind of frightening is actually that we can aerosolize live organisms, particularly viral particles. And one of the ones that's best studied is the human papillomavirus. And human papillomavirus in the last couple of years has actually become known to be a significant, with respect to causing a significant amount of malignancy in later years. So there's a number of HPV types. The HPV 6 and 11, basically with anogenital warts and warts in the upper respiratory tract. And then there's another type of human papillomavirus that's more associated with oropharyngeal cancers and cervical cancers. So the CDC, particularly with the interest in the HPV in the last 5 or 6 years, the CDC looked at the number of studies out there on the HPV with respect to potential transmission in healthcare workers. And they noted there was significant potential for HPV disease transmission, particularly from inhaled viral particles from energy sources during vaporization. Actually, so in one study, there are actually several small case studies that their operating room personnel in the operating room that weren't well protected during vaporization of anogenital warts, and within 6 months ended up with the same genetically identical HPV in their airways. So again, this is potentially a significant issue. So that when you have an energy source, when you're bovying, when you're using a source that develops smoke, you need to evacuate that smoke to the degree that you can. Again, they're active and passive systems, much like the gas scavenging systems. And lastly, I want to talk briefly about radiation hazards. Radiation, again, we don't see radiation, we don't feel radiation in generally, but we all have to be aware of radiation in our practice. So the students, as you come into practice, you probably have another good 40 years at least of practice, and that's a tremendous amount of potential radiation exposure, particularly as we go on to technology that's more powerful. The risk only tends to increase. So the radiation dose, the state of Texas actually regulates this quite rigorously, setting limits on basically the radiation limits for occupational radiation exposure. And again, when you get a potential radiation exposure, again, the acute is the erythema and the dermatitis, and the large whole body exposures cause nausea, vomiting, diarrhea. Those are big acute exposures. What we have to be concerned about is the chronic indolent exposures, the x-rays in the emergency department, or those of you that are going to go into orthopedics or vascular surgery that are going to be using the fluoro, or the cardiovascular surgeons using the fluoro quite frequently. again, that's a high energy or a high energy device, and you have to protect yourself. So the biological effects of radiation, there's basically two biological effects. There's a stochastic effect. So basically, this effect is really that you get the principal hazard is from the X-ray, and the pathology, the probability that you'll get the pathology is really dose dependent. The probability that you will, the sort of the rate or the severity of that process is actually independent of the dose. So once you have a dose of radiation till you get cancer, that's dose dependent, but what your cancer does after that has nothing to do with the dose of radiation. And the things that we are concerned most about, again, this is what we all are most concerned about with respect to radiation exposure, is the cancer, is the potential mutagenesis of radiation, although it's fairly low. The biological, there's deterministic effects, and these are basically strictly dose related. So your dose and your outcome or the sort of the onset of the pathology and the outcome of the pathology are both dose related. So some of the most significant issues as healthcare providers are specifically with the eyes and basically with the skin. Death is, again, fairly rare. Exposure risk is going to be contingent upon how long you're exposed, the energy of exposure, the standoff distance, and the type of shielding. So you should always, when you're in an environment that you're using x-rays, again, you should actually be aware that an x-ray is being taken. Use appropriate standoff distance. If you're sort of a routine chest x-ray, the standoff distance of about 6 feet, there's almost no detectable radiation, okay? The fluoro in the operating room, it's about 5 meters, so about 15, somewhere between 15 to 17 feet, there's no detectable radiation. So if you don't have to be there, don't be there. If you do have to be there, use appropriate protection, use appropriate personal protective equipment. So use your lead gowns, use your thyroid protector, and any other device, any other shielding device. Again, there's a number of studies out there. There's a recent study that was put out by the interventional cardiologists and interventional vascular surgeons that showed that those specialties were 3 times more likely to have significant skin lesions, 6 times more likely to develop cataracts, and 7 times more likely to have orthopedic problems, so related to bone density and the like, not fractures. So that's why, again, if you get anywhere within the, if you're supposed to or proposed to get anywhere within the 10% of the maximal dose of radiation exposure, the hospital should ask you to wear a dosimeter, and that dosimeter is checked on a periodic basis to basically make sure you're not getting too much radiation exposure, basically audits your radiation exposure. So we'll just close that, again, these are significant problems. Again, we don't think a lot about them because we have other things to do. We're learning the practice of surgery, we're doing surgery, we're taking care of patients, but we also have to take care of ourselves, and there are risks out there. So it's important to be familiar with all the risks of your environment and take appropriate preventative measures. And thank you for your attention. I'll be happy to take any questions.
For the radiation exposure, something I think about a lot, especially when I was pregnant, I had to declare each month and wear an inner lead and stuff. So I definitely learned a lot about it. But as far as the cataracts, at the VA, I know I have extra sort of blank glasses. So when anybody rotates over there, if they ask me, I have them in the Texas next to the OR. They're heavy. They go over top of just, they can even fit over top of extra glasses. But it's worthwhile if you're rotating on service for a month or whatever to put those on. And I try to remind everybody. We generally, I think, have enough lead in most of the places now that people can get a nice wraparound, you know, not just a little vest on the front without a thyroid shield. we should have most hospitals now enough to cover everybody, but it's important to do.
Absolutely.
Dr. Dent?
Yeah, Brian, great talk, and I want to kind of echo what Dr. Pound said in terms of locally, she's been very proactive about this. And I think this reflects a lot of the stuff that hasn't caught on among surgeons. It's kind of like I went to a conference in August, we were looking at patient safety and like with all the initiatives across the nation to reduce wrong site surgery has gone up. Not because people aren't making enough rules at a national level, but because people aren't embracing the rules
Right.
at a local level.
Right.
They're seeing them as regulatory bullcrap that I don't want to follow. So they're recognizing they're for your safety and they're for your patient safety. And like Dr. Pounds has done, taking a leadership role on her service, I think a lot of us need to embrace this sort of thing a lot more to help surgeons and patients.
Absolutely. And with respect to that patient safety initiative, it's interesting that there is an evolving body of literature that suggests that the surgeon that's impaired by disability from pain, from basically ergonomic challenges, there is an incremental increase in patient risk. So we need to take care of ourselves again, at the behest of taking care of our patients.
Ryan, you can't emphasize enough about the ergonomics. Our faculty were always honest about posture. It sounds like your mother talking to you, but posture is very important. And I know a lot of times we end up bending over, but the more time that you can stand straight up, it's going to be less strain on your back. And we had always talked about having the table at the level of your elbows, and so that was a very good point, a good take-home point.
Yep.
The problem with minimally invasive surgery, again, is ergonomics. We're operating like this because of the instruments and the trocars and the position of the patient. Most of us talking nationally, I think just about everybody has rotator cuff problems, whether it's that or other things in their life, sports or whatever, may impact upon them.
Right. We all had lives before we became